Hi everyone, welcome to researchmd.com. We have another interactive case discussion today. So let's start.
Okay, so this is a 63-year-old male, was brought to the ED by his wife, complaining of headache.
53-year-old male.
63-year-old male.
63?
Yes.
Okay, 63-year-old male, and what is the main complaint?
Headache.
Okay, I'll just write here. So let's start with the headache. Okay, so I'm just going to see the first word you said, 63-year-old. Why should we worry about 63-year-old with a headache? Why is it important? Should I be worried? A 35-year-old come with a headache and a 63-year-old. Which one I should be worried?
63-year-old.
Why is that? It's one of the red flags, remember.
Okay.
Okay, at 63, anything somebody with greater than 50 years old come with a headache, it's kind of becoming a red flag. They could have like some other, serious consequences. Always remember that. And the next one I'm going to say male. Why should I worry about a headache with the male? Is headache common in male or female? What is it common in?
Males.
Headache, when you look all around, who got more? Is female.
Female.
Usually, if you look at it, more headache, if you take 100 people with a headache, is more common in females. Now we got a question. You got a male patient with a headache. What are the most common headaches in male patients? What are the two most common?
Cluster headache.
Cluster headache, very good. So if I'm writing an examination question, if I put a 63-year-old male patient come with a headache, always kind of think about cluster could be like one of the other reasons. What are the other reasons for headache in men? The most common cause of headache?
Tension?
No. Coital headache. Okay. Coital headache is also common in males. So if I'm writing questions about a male, I always kind of focus what's common in there. One is cluster, and the one is the coital headache. Okay, two headaches. So let's talk about in some of the when you talk about somebody with a headache, what is everything? What is the first thing I would say? What are the emergencies, right? If you don't act on it, the red flags. This is the one you have to act on it right away. It doesn't give you much time, and these are emergencies. Okay, so let's look at those emergencies. So fortunately, we are a mnemonic. Okay, what is a mnemonic name? Anybody know? For the headache. Okay, Snoop.
Snoop.
Right? S N. What else? What's the next one? 2N, right?
Yes.
Okay. What else?
There are 2 O's
You got 2 O's
and 10 P's.
10 P's, right? 10 P's. So you tell me what these are. You got 1, 2, 3, 4, 5, 6, 7, 8, 9. I'm running out of space for my 10 P's. Okay. So what is the first one? The first S is for systemic signs, right? What are the systemic signs? Fever.
Infection.
Okay, infection or fever. Why should we be worried about somebody with a headache and fever, neck pain? What's the diagnosis?
Meningitis.
Meningitis.
So systemic signs. Okay, I'm going to write systemic signs right here. N.
Any neoplasm?
Neoplasm. Okay, so anytime somebody's an emergency, right? When you have somebody with a headache, usually what are these people are, how does it work? Headache wake them up at night when they go to sleep. Those kind of things is associated with weight loss and all that. Neoplasm is the second one.
Yes.
And the other one, N, is neurological deficit, okay? Why should we be worried about neurological deficit? Right? Could be a stroke. Right?
Yes.
So another reason could be a stroke. And the other one, and then you got 2 O's. What is it? Onset. Okay? What is it? Why is it onset? Because sudden onset is another bad sign. Sudden onset of severe headache, thunderclap headache, and those kind of things, a very, very bad situation, right? You got an subarachnoid hemorrhage, those kind of things, right? You got that. And what is the other O? Older age, right? So we already talked about this guy is 63-year-old, right?
Yes.
When you have a 63-year-old greater than 50, that's a bad sign also, okay? What is the next? First P, pattern, right? the change in the pattern of the headache going from one and the other extreme and those kind of things. So you always have to worry about some, major things kind of going on. And then positional headache. Okay?
Yes.
What are the positional headache we need to worry about? What kind of thing?
Intracranial
That could be
hypertension.
high intracranial hypertension. When you bend over, you have a headache, right? Those
Yes.
kind of things is also very important, okay? And then what is like precipitation, right? Like an exertion. Let's say like when you say precipitated by sex, coital headache. We already said this guy got like as a man, it's more common. Then we need to know coital headache is precipitation factors, right?
Yes. Sneezing, coughing.
Okay, sneezing and coughing. That's like also increases the intracranial blood intracranial pressure and all that. Okay, what is the next one? Papilloedema, right?
Yes.
Why should we be worried about? Again,
Intracranial
intracranial hypertension, right?
Yeah.
Let's say like, if you have, idiopathic intracranial hypertension, obese patients and those kind of things can also, right? Can cause, so you have to worry about papilloedema. What is the next P?
Progressive headaches could
Progressive headache. Anytime it's getting worse, then again is a red flag. What is the
Yes.
next one? Next P?
Pregnancies.
Right? So we talk about pregnancy. Right? You can have like during the pregnancy what? What can you have? Preeclampsia
Preeclampsia.
and a lot of complications during the pregnancy to the mother and the fetus, right? And then you have painful eyes, right?
Yes.
What situation?
Mm.
I mean, glaucoma is like one of the, if I have to
Yes.
think about like a unilateral painful eye, glaucoma is again an emergency, right? And then you have like what?
Post-traumatic.
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 Yeah.
So we always have to ask the patient, like, what happened in the injury? Was it an accident or something happened to the brain or anything? Okay, and then what are the other thing? What is the next one?
Pathology
Any
of immune
pathologies
systems.
could be.
What is it?
Any pathologies?
Any pathology,
Yes.
like any previous pathology or like pathology in the brain, like brain mass, even pathology maybe an
HIV
aneurysm, right?
HIV.
Pathology could be an immune, let's say pathology from HIV, that's another thought, like immunocompromised. What happened in HIV? Cryptococcal meningitis can increase the intracranial hypertension and all those kind of things, right? And the last one is, I would say, pleasure-seeking drug, right? Pleasure drug. What are the one you just have to worry about? Mainly we need to worry about cocaine and all those kind of things.
Yes.
Okay, so we have, so remember all this mnemonic, right? This is the red flags of the headache. That is my first thing. Anytime somebody come up to me and say like, hey, your doctor called me and said, I got somebody with a headache. My job is to make sure, go through Snoop, 10 mnemonic and make sure like I didn't miss anything kind of very serious. Okay, then we just kind of talk about like, some of the other common headache. So when you talk about the common headache, let's talk briefly about headache. What are the most common headache? We got like everybody know. Migraine, tension, and cluster headache, right? These are the main thing we just kind of like and all those kind of things. But before we go into that, tell me a little bit about the headache, right?
So it's pulsating and bilateral.
So it's pulsating.
Yes, and
It's
bilateral.
bilateral. Okay, so which headache, is more like a bilateral headache? Tell me somebody like, which one is
Tension
bilateral?
headache.
Tension headache is bilateral. Okay, so we need to worry about it's a bilateral headache and all that too. And what other thing? Any other?
Okay, and she has his wife said that she noted that he has high blood pressure.
Oh, okay. So we know, like, now the patient wife is saying he's been having high blood pressure at
Yes.
home, right? Can blood pressure be associated with the headache?
Yes.
Yes, right? Hypertensive headache you can have associated with. Usually the blood pressure greater than 180, those kind of thing, we'll just kind of come back to that. Usually, like, what are some characteristics of like a hypertensive headache? They are bilateral. They usually like pulsating or throbbing type of pain, okay? They usually like, what is the time duration? They usually like less than an hour.
Okay.
And once you control the blood pressure, the pain, the headache goes away. So it's just a dramatic change. If somebody with the blood pressure, they come in and you control the blood pressure and you should dissipate in like in an hour. If it doesn't go down in an hour, just kind of think something else kind of going on in this patient. Okay? So we know, the only thing we know about this patient is complaining, it's a male patient, had a headache, but he's been having high blood pressure at home, it's bilateral headache, but not associated with all the other kind of thing. He didn't say it was a thunderclap headache or those kind of thing, right?
No.
Now just talk about like what are the three main types of headache. You got migraine, what else? We have
Cluster headache.
cluster headache,
Tension.
we got tension
Tension.
headache. Okay, so the number one question I'm going to ask, what's the most common headache in the United States?
Migraine.
Migraine? Wrong. Fired.
Tension.
Okay.
Tension headache.
Tension headache. Okay, if you have to think, somehow everybody's mind every time we say like it's migraine, but it's not migraine. Tension headache, remember that. Okay, migraine, let's start with the migraine. Okay, so what is like, there is a great mnemonic, right? For like, let's talk about like pound mnemonic can use. Okay, pound mnemonic is like a pulsating. Okay, and then also talk about the onset, right?
Right.
And U is what? Unilateral.
Unilateral.
And N is like what? Associated nausea, vomiting.
Right.
D is disabling.
Okay.
So if you use the pound mnemonic, the sensitivity and specificity for pound mnemonic in migraine headache is high. Okay, so anytime a patient comes in, if you suspected migraine, use the pound mnemonic, P-O-U-N-D, my friends. Okay, always very good. And then usually, what is it? Unilateral, bilateral?
Unilateral.
Unilateral. Then you can like later on kind of thing. Okay, tension is
Bilateral.
bilateral. Okay, band type and all those kind of thing. Then to talk about cluster headache. Why is it cluster headache is interesting to us? First of all, we know this is a male patient, very common in male. Always remember that, okay?
Yes.
If I see like an examination question, like a 45-year-old come with a headache in the male patient, most likely they're going to be talking about a male patient. Remember that, okay? And then what we have to do is like cluster headache, give me some characteristics. What kind of questions can I ask if it is cluster headache?
Symptoms.
Yeah, what is like, okay, symptoms of cluster headache is kind of different. It's kind of retroorbital, right? And the conjunctival ingestion and all that. And then you got like autonomic symptom, or autonomic symptom is very common in these people, okay? And there's something unique, like, some studies have shown if somebody have cluster headache and, all the other headache, you don't start with a CT scan and MRI. You don't do that, okay? Only the people, cluster headache, there is some, I think one study found out there's like 5 to 10% of intracranial abnormalities. So if there's like one headache, I'm kind of suspecting cluster headache. I think this is only time I'll say like pick an answer for an imaging study, right? For an examination, for a patient come in headache, and if you took a CT scan, most of the time is kind of wrong. Okay? Unless it's like a red flag and those kind of things. Remember that. So cluster headache, I will take it seriously a little bit. What are the other uniqueness of the cluster headache?
The duration.
Duration, okay, what else? Treatment, let's talk about treatment. Why is something unique about?
We give supplemental oxygen.
Oxygen, okay, oxygen, if you give like 100% oxygen, they have relief. They also, steroid have also a role in it, okay?
Right.
So think about all three. Definitely a lot of questions. So many different headaches are there. I think last time I looked at the international classification of headache, there's like around 200 different types of headache. But we need to know like what are the red flags, what are the most common things. That is the only thing we need to know, okay?
Right.
So based on at this point, right, we can say what are the we can say we think this could be maybe a hypertensive headache and associated. That's the only thing we know. At least we didn't see like the other red flags and all that, right?
Yes.
Let's talk about the past medical history.
Past medical history is positive for anxiety and hypertension.
Hypertension, right?
Right.
So, any other past medical history we need to know? All of this thing, like, history of malignancy,
Yes.
right? We need to know. Is there like history of aneurysm? We need to know, right? All those kind of things we need to know. History of like if they're in HIV or those kind of things, infections in the past, we need to know, right? Those kind of things. And what is the other one? Allergies?
Allergy to penicillin.
Penicillin. Okay, what are the other things?
Family history is positive for hypertension, both in father and mother.
Family history is hypertension. Anything on the family history we need to know? We need a history of aneurysm, right? That kind of like somebody runs in the family, you know, that we need to know. Okay, and then what else? So, I mean, medication. What medication he takes?
So the patient is a losartan, but he's non-compliant.
Is a non-compliant patient?
Yes.
Okay, okay. So he's taking losartan?
Yes.
Okay, right. Why do we need to worry about the NSAID? It can have like medication induced commonly like
Yes.
NSAID use and all that. We just kind of need to ask, hey, what do you like the best way? Like, do you take any pain medication or something? Okay.
Right.
So we need to know that. Now, social history. Why do we need to know the social history?
Social history.
Why?
If he's a smoker or
Okay, smoker. I mean, kind of associate. What else? What else they smoke?
type of work he's doing.
We'll come back to that. What
Illicit
else?
drugs.
Huh?
Any
Drugs.
illicit drugs.
Illicit or pleasure-seeking drug. Up
Right.
here, we said that already, right? What do the people usually take? Common now, cocaine. What does it cocaine cause?
Yes.
High blood
Happens.
pressure, headache is very common in this patient.
Right.
So very important to get if this patient have like, does he smoke?
No.
I mean,
No,
anything,
he's
no
not smoking.
recreational
No,
drug,
no
right?
recreational.
Alcohol use, not that much important, but again, it can cause like blood pressure and all those kind of high.
Right.
Sexual history, why should we know about sexual history in this patient?
Coital headache. You were talking about.
Yeah, I mean, I think coital, headache, that is we need to know. What else? We said like HIV, right? If the
right,
patient
yeah.
have like, sexually transmitted diseases. Even syphilis have like, the CNS manifestations also, right? So it's very important to know. Any history of HIV, syphilis or anything?
No.
Okay.
It's actually not.
And then psychiatric history? Do we need to know? Of course, right?
Right.
Everything is complete. History and physical, we need to be very thorough. I mean, the associated with the headache and the psychiatric disorder is also very common. Now, let's go to the physical examination. We'll start with the vital signs. Give me the vital signs.
So his blood pressure is 223/94.
223/94, okay?
Temperature is 98.2 Fahrenheit.
98.2,
Yes.
okay?
Pulse is 76.
Uh-huh.
Respiratory rate 18.
18, okay?
Saturation 97%.
97%,
Right.
okay. So what do we know? We know there's like high blood pressure right here. Okay,
Right.
what else is kind of different about this? What is that called?
Hypertensive crisis.
What is it? What is the difference about it? Why is it so? High pulse pressure, right? Look at the
Yes.
difference between and all those kind of
Systolic
things. So
diastolic.
what are the things kind of common in high blood pressure? Like aortic regurgitation,
Aortic
okay?
regurgitation.
Those kind of things you have to kind of remember.
Right.
We need to. I'm just kind of saying. I'm not saying this patient could have, right? I'm not so sure about it. But you have like a high pulse pressure. So many things can cause widened pulse pressure. Only
Right.
thing I know, there's a widened pulse pressure. I
Right.
still don't know what causing. But aortic regurgitation, kind of the like some of the. I mean, one of the causes and all that too. What else I should know about in the vital signs? Do we need to know about the weight? Do we need to know about the BMI? And why should I know about a BMI in a patient with headache? What, I mean,
Pseudocerebral.
I already said papillary edema,
edema.
obesity, what is the association? Female, idiopathic,
Pseudocere-
intracranial hypertension, pseudotumor
Yeah.
cerebri,
Right.
okay? Just remember that. Those can also kind of, thing, we need to know what is the BMI, high BMI is associated. What else high BMI is associated with? Right? They have sleep apnea, obstructive
Right.
sleep apnea. What do the people usually like? What is the common headache they get? They wake up in the morning and they can have headache, right? When you have a headache in the morning, always kind of think about usually what happens because of the obstruction, obstructive sleep apnea. They can have CO2 retention, and they usually wake up with a not a headache. So remember that. Always get the BMI also, right?
Okay.
And then just talk about like what examination we're doing, right? We need to examine the eye, right? So like what was the examination finding? I mean, I think that's very important. I need to make sure there's no, neurological examination, I would be very thorough. Let me see, cardiovascular examination, we already said, I would look for a murmur on this patient,
Yes.
okay? Was there a murmur or
Yes,
anything?
there is a murmur.
What type of murmur?
Systolic murmur. is
Systolic murmur. But systolic murmur, like what is the murmur in aortic regurgitation? Systolic or diastolic?
Diastolic.
Diastolic, more like a diastolic kind of murmur, but I'm just kind of I'm just kind of worried, like what, is there like an association, aortic regurgitation in there? But when you talk about systolic murmur, I mean, usually it's common, right? Systolic murmur, if it is only greater than grade 2, investigate it.
Okay.
Okay? And because, I mean, or if it is like associated with any other, like shortness of breath and those kind of things. Okay? Because it's very common, like a benign murmur. When you only have like a systolic murmur less than 2, you don't have to investigate it. Okay? So we talk about, and then we talk about the neuro exam was completely normal.
Yes, it's
no
normal.
deficit or anything.
No.
Okay, nothing else kind of going on. The examination didn't tell us. So what investigation? What are the labs we need to check?
Okay.
CBC is important.
Yes.
Okay. Why is that?
Any infections?
Infection, WBC, right? We need to worry. What is
Right.
it? Well, let's write some of the labs right here. What is it?
Okay, so WBC 7.5
7.5. Okay.
and hemoglobin is 16.3.
16.3. Okay.
Okay, and the platelets is 144.
144.
Yeah.
Right? I mean, sometimes if any of this kind of elevated also, you can have headache, right? We have like blood blockage and those kind of thing, right? Even platelet goes up like greater than like 1 million. Polycythemia also, right? We need to worry about that kind of headache.
Absolutely.
Any other abnormality in the CBC?
Absolute lymphocytes 0.9.
So we got decreased lymphocyte, right?
Right.
So which condition we can link a blood pressure and decreased lymphocyte?
Okay.
Which maybe I'll give you a clue, like viral infection and all those kind of things, right?
Okay.
Somebody have HIV, they can
Yes.
have like,
Yes. Right.
lymphopenia, right? And maybe in this patient, I'm not saying this patient has it, but I just kind of like, circulate everything. You just kind of like, kind of link together. That's what make the, greatest doctors, right? Instead of saying like, oh, I got hypertension, I got lymphopenia, I got renal failure, you need to combine all these things together
Right.
and come with a diagnosis. Then that make the best doctor we can. So we have, and then what are the other things we need to know?
Glucose 123.
Okay. We know blood sugar, if it is high, that can cause like a lot of problem,
Yeah.
right? What else we need to know?
Potassium is 3.2.
Okay, potassium is 3.2. Why should we worry about potassium with a headache?
Hypokalemia. causes-
Yeah, which disease? Maybe sodium can high, potassium low, high blood pressure, come on.
Increased aldosterone.
Yeah, aldosterone, hyperaldosteronism,
Hyperaldosteronism.
we need to kind of think about it, right? So just kind of like we can talk about that, maybe like one of the causes, we don't know. I'm just kind of saying like what
Right.
kind of anything, okay, what else?
So-
The sodium was
sodium-
normal, now
yes.
interestingly there an increase in sodium.
So it's like 147.
Was normal?
Yeah.
Okay, normal, I think, I don't know, 46 or 140.
145.
Oh, 145. Okay, so that's normal. But I'm worried like there's a low potassium in this
Yeah.
patient, okay? Any other labs? What are the other labs we need to see?
So bicarbonate 29,
Okay,
chlorine 100.
okay. So what does that tell us when it's bicarbonate 29, right? I mean, this patient had probably like what a metabolic alkalosis. Kind of see like, I don't know, this patient obstructive sleep apnea, you can have CO2 retention. That can cause like, long-term metabolic alkalosis kind of thing, right? So, do we have what about the other markers? Do we have troponin?
Yes.
What is a troponin?
So troponin is 0.4.
Troponin 0.4, is that high?
0.04.
Okay,
Yes.
it's high, all right?
Right.
So we got a troponin high. Do we have an EKG?
Yeah, EKG shows normal findings.
EKG normal. Okay, any other investigations done?
So the patient has undergone CT head without contrast.
Okay,
So which showed mild atrophy with no acute intracranial hemorrhage.
so non-acute,
Yes.
right? We'll just say with the normal limits, right? So all this investigation, so like now we looked at it, we got the labs, we got the vital signs, we got the examination finding. Let's come with our assessment and plan. And what is our number one diagnosis, my friends? Tell me, what is the number one diagnosis in this patient you would put?
Hypertensive headache.
Okay, hypertensive or like, I mean, you know, the best, when I look at a patient, I say, what is the maximum, you know, billing capability I can have a headache also, right? I have to justify, I'm admitting this patient to the hospital, right? Why should I admit this patient to the hospital, right? So, I mean, which give me the highest diagnostic kind of thing? Which one? I can say hypertensive, what? Crisis,
Okay.
okay? Number one, I would say, hypertensive crisis.
Okay.
I would say blood pressure on arrival is what? 223/94, right? And what is the difference between urgency and crisis? What is the definition? Come on.
With end organ damage.
End organ damage, that's what I'm looking for. What is the end organ damage in here? What is the end organ damage? Come on, think. Is this an end organ damage?
Yes.
Yep,
Yes,
so we got
cardiac.
troponin elevated.
Yes.
So increased troponin. So I can say high blood pressure.
Yes.
And even you can have like blood pressure greater than 170 and you can call it like hypertensive crisis. Okay,
Right.
there's no target organ damage, you can say like hypertensive urgency, right? So that is like a CT scan was normal. Now we wanted to, what are the things we have to do? What is the other thing we haven't done in this patient? If
Urine analysis?
urine analysis, no, urine toxicology screen, remember?
Okay.
We said like a UDS, was it done?
No.
Okay. Is it important? Because we already said like could be cocaine, right?
Yes.
Right.
Why is it important when we know hypertensive crisis, right? Why is it important in the blood pressure management or cocaine? You have to be careful when you use the beta blocker,
Beta blocker.
Yes.
right? You can unopposed alpha action, so it'll be very, very dangerous to the patient, right?
Right.
So you have to like, that's why, I mean, I would have checked on you anytime somebody come in, it's not a bad idea to check urine. He's a non-compliant patient on top of that already. Who knows like whatever he's doing, yeah? Check a UDS, and then you can use the blood pressure medication, the hypertensive medication. Maybe I would start with hydralazine IV, right?
Yes.
Right.
Now, you know, we just wanted to decrease maybe 20%. You know, the mistake people make is like jump in, become, you know, very fast trying to bring the blood pressure down. That is not allowed. Just do it like permissive hypertension. I would decrease maybe, you know, 4 to 6 hours, I might cut down like 20%. If, you know, this guy, I mean, that's what I would do. If you want to use a blood pressure medication, maybe IV hydralazine, like a small dose, or you can use like clonidine, those kind of thing to bring it in, right? I use a PRN, or I might use what? Vasotec IV. You can use like, you know, metoprolol and those kind of thing, like anyway kind of thing. But the rule number is like, don't try to bring in too fast. I see this all the time. Patients come to the emergency room. The first thing, you know, when you walk in there, they already decrease the blood pressure like to 100. Imagine like, you know, brain is kind of used to that blood pressure and is coming like so down, it's going to be a problem, right? Anything else we need to do? They already said like a CT scan negative, right? I can say like, you know, CT goes negative, we'll monitor. And I would say permissive right? Permissive hypertension, that is. And the next one I can say like, you know, the headache. I can say, you know,
Yes.
headache associated with hypertense, headache, possible cause due to high blood pressure, right? So just, so we know the headache with the blood pressure, right? We usually like bilateral, right? We said it's already like pulsating headache. And we say like after you control the blood pressure, within an hour it should go down. And usually like less than 1 hour, those are the main thing we need to worry, right? And what are the other thing I can say? Like, I mean, I always kind of put this, you know, kind of link together. Anything abnormal I see, I'll write it down. I know hypokalemia, right?
Yes.
Right? And then I will say I'm worried about aldosteronism also kind of
Right.
causing, right? Maybe it's kind of linked to right here, this blood pressure kind of thing, right? So I can check, you know, investigation, like, I mean, rule out, hyperaldosteronism, right? Do the
Yes.
workup for that, okay? Because we know like potassium is low, right? Those are the main thing and all that too. We can always say like, I mean, the lymphopenia, maybe check for HIV, but I think a lot of people, everybody had like an HIV test, most of them done anyway, some of the places. Anything else? We can say like the troponin is elevated, right? I mean, even though we said it like, I mean, we can say troponin elevation. What are the plan for that?
Cardiac consult.
So you do serial troponin.
Okay.
You said cardiology consult.
Yes.
Okay, before like, I mean, that's not an acceptable answer.
Okay.
Don't put like when you say troponin elevated cardiology consult. Anytime before you consult, I get really upset if somebody said like, elevated troponin, consult cardiology. So why did you go to medical school? Why did you learn all this in nursing school, PA school or in college and all that? God has given you a good brain, right?
Yeah.
You should use that to think it. What causing it? Anytime before I consult somebody, 2 questions I ask. Okay, what is my clinical question? Okay, is my clinical question is like, I don't know how to treat elevated troponin? Or the second question I ask is the consultant is going to do anything different than I'm doing? If I don't have answer to that, I will not consult. So if you don't give me those answers, right? I know elevated troponin, I know how to investigate it, right? I know the blood pressure is high, maybe demand ischemia could be like one of the, so I will do the investigations first. I will do serial troponin, right? I will do EKG, right? To roll out all this non-STEMI kind of thing. And then, if I need like, maybe an echocardiogram because there's a murmur going on to find out what's going on, okay? And then once all this come back up, maybe outpatient basis, we could do like a stress test or something, but not immediately. Okay, so that's the way I approach this case. Thank you so much for the presentation. Please make sure whoever watching, if you could put the comments, and if you disagree with the management, anything else you would have think we should have done differently on this patient. This is a great case. We're going to be doing like series of cases kind of every day. It will help you how to present a case to the attending, what kind of questions you can ask, okay? It's very, very important your participation. Put some comments about this case, why, you think, be critical. That's the only way we can learn and we can be better, okay? Thank you so much for watching. We'll be back with another presentation soon. Thank you.